So for any of you who weren't on the earlier call that we did, my name is Dr. Lynn Silver. I'm based at the Public Health Institute. I'm also on faculty at UCSF. And my background's, I'm a pediatrician by training, but I've been in public health and public health policy for about 40 years now, working on different issues as university researcher, consumer advocate, public health official in New York City, and county health officer. I'm working on many issues, a lot of which involved regulation of harmful products, including food policy, pharmaceutical policy, tobacco. So about 5 years ago, actually more than 5 years ago now, 7 years ago, when cannabis was being legalized in California, we started this project to try and really bring lessons from tobacco control and other areas of public health to the regulation of cannabis where it's being legalized. And a big part of that was trying to understand what was factual and correct about health effects of cannabis, both positive and negative, so that we could talk to people about it in an honest and forthright way, so that they could understand the population health effects that should drive our decisions about cannabis policy. So we'll be doing this series of talks for you. This is the first substantive one on health effects. This next one will be on regulation and policy aspects. The third one will be on equity. We did receive an inquiry about messaging as well. So the group is really here to help initially the project officers deepen their knowledge on these issues. And then to help you help your grantees and other community partners. And we're also going to be available to help community partners share expertise, develop tools, and so forth as part of this collaboration. We've been working like crazy with Minnesota for the past few weeks, some with Ohio, also New York State's Association of County Health Officers pulled us in this week as well. So it's been a crazy time with a lot of cannabis policy work going on. So I'm going to introduce Dr. Nima Shahidinia, who recently joined us to support this collaboration with CDC and with ASTO. And he recently completed his PhD on medicinal cannabis at RAND Corporation, and has worked with NASDAD and substance abuse programs for a number of years. So Nima will be doing the presentation. I'll chime in. Before I hand it over to him, I just wanted to ask, are there any particular issues on health effects that people have as burning questions in their heart that they know about, that they've seen, that they're worried about, that they want to make sure that we cover? You can speak up now and say them, or you can put them in the chat and we'll try and make sure we address them during the talk, and then there'll be plenty of time for questions and further discussion at the end. So before we get started, anyone want to just unmute yourself and chime in if you have a specific burning question that you'd like us to address on health effects?
If for some reason you're unable to unmute, let me know so I can chime in and make you co-host and give you that ability.
Okay. And you can also put something in the chat if you wish.
Any burning questions? We will have at least 10 minutes at the end for folks to ask, but if you think of something, please feel free to put it in the chat. We'll make sure to monitor that.
Okay, because this is complicated stuff. I'm confused. Right. All right, take it away, Nima.
Sure thing. A lot of open minds today. Well, thank you, everybody. So we have a lot of ground to cover, but again, we'll leave room for questions at the end. Today, we're going to cover the health effects of cannabis, both the therapeutic effects for a small component, but also focusing on the harms and what public health concerns we have. So for the first half of this presentation, we're going to look at a quick review of cannabis itself and what we know about the therapeutic effects, as well as the types of products you're likely to see in cannabis shops. And then in the second half, we'll talk about the rising levels of THC or other intoxicating products in cannabis and why that's an issue of public health concern. And then we're going to look at the harms that we know of that high THC levels can cause. So very quickly, if we look at cannabis itself, It has over 500 active ingredients, but what you often hear about are cannabinoids, or the 100 or so ingredients that are unique to the cannabis plant. THC and CBD are the two of the most abundant cannabinoids, THC being the active ingredient that gets users intoxicated or high, so to speak, whereas CBD has non-intoxicating properties. Hemp is the same thing as cannabis, the key difference being that it has a lot lower THC. There's a legal limit of 0.3%. Now, hemp-based products can still have intoxicating products such as Delta 8 and so forth that can get users very high and still stay below that 0.3% limit. The 2018 Farm Bill legalized hemp across the country. So this is a major loophole that states have had to deal with. The fact that hemp-based products can still have intoxicating product and still meet that limit. A lot of states have chosen not to regulate this issue very heavily, though. So keep that in mind. Looking at the therapeutic effects, as project officers, you may be confronted with and asked about what the therapeutic effects are. And so this is just a good thing to keep in your pocket. Here's what we know so far in general. In the US, there are two drugs, synthetic THC, not to be confused with K2 or spice. Those are completely different things. Dronabinol and nabilone, or the brand names Marinol and Sesamet, they are known to treat chemotherapy-induced nausea. There's also a CBD extract called Epidiolex that can treat certain forms of epilepsy. There's also another drug that isn't FDA approved known as nabiximols, which is an extract of THC plus CBD that can treat spasms related to multiple sclerosis. Now, keep in mind, I bring up all of these brand names because none of these products can be sold in cannabis shops. They have to be prescribed. And again, nabiximols is still not FDA approved. The only product you can get in cannabis shops are inhaled cannabis through vape or smoked form that has been shown to treat chronic pain in adults, but as any manufacturer will tell you, dosing in cannabis plants is very hard to control. When you go to the pharmacy and purchase a drug and you get consistent dosing, this isn't the case with inhaled products, not to mention the harms of smoking, which we'll bring up later in the presentation. Other than that, unfortunately, we don't have a lot of clinical evidence on the therapeutic effects of cannabis yet. It doesn't mean it doesn't exist, and federal laws for decades have made cannabis research very hard to conduct. So we might discover new things in the future, but for now, there are dozens, over 70 health conditions across US states that allow you to get a medical cannabis card, but for which there is very little clinical evidence. There are several examples we've shown up here. This is a big problem if patients are trying to get or cannot get the care they actually need or have mental health issues, which can be an issue with high THC products. And again, we'll discuss that later in the presentation. But first, let's part ways. Let's look at what kinds of products you're likely to see in cannabis shops. And we were asked about different routes of administration, so I'll break it down by product type. The first one is more classic. These are products you can inhale. There are many ways to inhale a cannabis product. You typically see cannabis purchased in flower form, that large chunk on the left-hand side, which can be smoked through either a cigarette or a water pipe, volcano vaporizers, or other devices. There's kief, which is formed from the trichomes or the little hairs on cannabis plants. They have more concentrated THC amounts of THC. And speaking of which, what's becoming more popular is concentrates, wax, butter, shatter, and so forth. These are made using liquid chemicals like butane to extract high amounts of THC in a single hit. These contain between 90 to 99% of THC, and they're highly potent. Now, in addition to products you can inhale, there are oral products. Now, you can see on the left-hand side, they do come in medicinal form like tinctures, oral drops, capsules, and so forth, lozenges. But again, these are not FDA approved. And what you're going to see pop up more often in recreational or adult use markets is what our team likes to call the kids menu. These are candies, edibles, drinks, beverages that are not only marketed, but manufactured to have a certain taste to appeal to teens and young adults. Now, you don't see it up here in the picture, but a lot of shops also have products that are designed to mimic existing candies and products like Skittles, Starbucks, and Snickers. Those are also something to watch out for that regulations should be designed to address. And finally, just as a footnote, there are other types of cannabis products. You see lotions, balms, topicals, and even suppositories in medical form. These are typically used for therapeutic purposes. And as you can see, there is a range of potency levels. Some have equal amounts of THC to CBD, some are higher in THC, vary, just like you saw with the oral products and the inhaled products. Now, we were asked a very good question in our last segment, which is if we could cover what the different effects are depending on how you take in the cannabis products. Here's what you need to know. Inhaling is one of the fastest ways for a product to take effect. Oral products are the complete opposite. It's the slowest. That is, unless you hold it under your tongue for a certain amount of time so that it travels through the bloodstream faster. This is typically what patients use with tinctures or oral drops. But otherwise, when you take something orally, it has to go through your digestive system. That means your body is taking the time to filter out the product for any junk. And because of that, edibles take a lot longer to have an effect, at least 30 or so minutes. Now, why is that important? Because more inexperienced folks who aren't used to edibles might be impatient and accidentally take in more than they need and get extremely high. And this is made worse when you take it in with fatty foods, which make the THC bind to the body a lot more. Now, my point being that, especially around children, if they get a hold of these products, that can lead to a lot of accidental ingestion and intoxication. And we have been seeing a rise in hospitalization and urgent cases, which we'll see in later slides. So for folks with oral products around the house, project officers, it's important that you message to keep these products locked away and out of reach of children. Very quickly, for topical products, Dr. Lin, correct me if I'm wrong, but these tend to be more localized rather than traveling throughout the body. But these are the different effects depending on what kinds of products you take. Now let's look at the rising potency, the rising THC levels. Like Lynn and I have talked to Brenton before, cannabis is not the way we knew it 20 to 30 years ago. The amount of THC in cannabis products is completely on the rise. What makes this worse is among both youth and adults, cannabis flower is still the most purchased product by both youth and young adults. And on top of that, the concentrated products, wax, butter, and so forth that I showed you earlier, those are becoming increasingly popular. Yes. Now, with the rising THC levels, we're seeing this both in the illegal market and the legal market. Here's some numbers from what we've seen over the past 15 to 20 years as far as jumping THC levels just in illicit seizures alone. And on top of that, if you look at this graph, notice that just in the illegal market alone, at the very bottom of the graph, the bright orange and the yellow line, while CBD content has been consistently the same throughout, THC, however, has been gradually going up. And this is also true in the legal market. This is a study looking at sales in Washington state between 2014 and 2017. And you could see among sales of cannabis flower, high THC products are dominating the market. Over 15, and in many cases, over 20% THC. And this has been going on over the last 3 years. And on top of that, remember what I said earlier, that concentrates, wax, shatter, and so forth are becoming more popular, represented by this graph right here. So you can see that cannabis flower is becoming more and more popular. It's still the most used among youth and young adults. And as you saw on the previous slide, of those flower that are sold, high THC flower is becoming increasingly popular. And on top of that, look at the graph. The light blue chunk that's getting bigger and bigger, that represents extracts and concentrates. So the point being, over the last two slides, what you're seeing is high THC products are dominating the market and becoming more and more popular.
It's actually hard to get low THC products now in many stores. I hear from doctors who work with medical cannabis, they can have a hard time even finding the lower dose stuff that they want for their patients. So that's just an increasing problem, that these really dangerous sectors have grown so quickly. So a lot of people vote for legalization thinking they're legalizing the joint that they smoked in college in the 1970s, which when I was a college student was about 4 or 5% THC. But in reality, we have this whole market of industrialized products, of luscious, delicious looking edible products, of things that really have almost nothing to do with the original botanical plant. And that's a major driver of why we're seeing problems that Nima will be discussing in a minute. It's the former Surgeon General said, it's not your mama's marijuana.
That's a perfect segue. So we're ringing the alarm bells here. Why are high THC products an issue? So yes, sure. We saw way in the beginning that certain doses of THC, some clinical products can have clinical applications, but otherwise frequent use of high THC products can cause serious health problems. The biggest ones we're seeing, not in any particular order, are number one, addiction or cannabis use disorders. Number two, having psychotic episodes or breakdowns. And number three, especially harms to kids who are exposed to THC, whether during pregnancy or later on in life, and the problems that could have as they grow up. Not to mention, by the way, traffic fatalities, which is in a later slide. So let's tackle the addiction issue first. A bit of myth busting here. You'll often hear that cannabis is non-addictive. That's not true. It can be. Perhaps not at the level of fentanyl or opioids, but it is still possible for frequent users, especially of high THC products, to become dependent. With all the usual symptoms that you'll see with dependency on other drugs, withdrawal issues, craving, using too much, interference with personal or professional life, and so forth. And the key factors here when it comes to cannabis use disorders is what kind of cannabis product you're using, when do you start, and how often do you use? Put very shortly, the earlier you start in life with higher THC contents and the more frequently you use at a younger age, the more likely you are to develop a cannabis use disorder. And the same is true of psychosis or schizophrenia. So frequent use of high THC products raises your risk of having psychotic episodes, which consist of a range of symptoms such as delusions, paranoia, disconnection from reality, seeing things that aren't there, hallucinations, voices, and so forth. Now, what's unclear, and Dr. Lynn, I'll lean on you to clarify this a little bit, is whether this is the extent to which this is a genetic issue. It's not known whether this is a naturally occurring issue related to high THC. THC use in high amounts has been clinically shown to have anxiety-inducing effects, but many patients who have these episodes have had a history of schizophrenia in their family. But the problem is most of us don't know what our genetic history is related to schizophrenia. So this appears to happen more often randomly.
Yeah, I would just add, so there's been a lot of back and forth on whether cannabis actually increases the risk of psychosis and schizophrenia. And it was the conclusion of, so back in 2017, because there were so many questions about these health effects, the National Academies of Science did a major review on both positive health effects and negative health effects of cannabis. And they reached a series of conclusions, many of which this talk today is based on, of where the balance, they looked at tens of thousands of articles and tried to say, okay, what does the balance of the evidence show us? Because there's you can always find a paper that says no and a paper that says yes. And so it's, part of synthesis of evidence, and often a role of the CDC is to synthesize evidence. That's what the community guide does, and the clinical preventive groups work on, is to find that balance of the evidence through good methods. And they really concluded, amongst other conclusions that we're talking about here today, that use of cannabis is associated with increased risk of psychosis and schizophrenia. That can range from having a transient psychotic attack when you get high and landing in the ER for a few hours, to having a definitive psychotic break that morphs into schizophrenia and from which you never come back, and everything in between. I spoke just yesterday, actually, with a woman whose son had come home from college with psychosis. The child was diagnosed as having manic depressive disease, which he wasn't a child, he was a young adult, which the mother felt was inaccurate, continued to have psychotic symptoms, and was home using pot heavily, in part to treat this very scary symptoms he was having of hearing voices and seeing things. And it took them about 6 months to realize that this was actually an effect of the cannabis use. And then when he stopped using cannabis, all the symptoms went away. He was fortunate that it was reversed with ending use, and hasn't had any symptoms since. Graduated college, is doing fine. But some people do not recuperate with cessation of use. They have a permanent psychotic break that can be cannabis induced, and other people do. But it's very complex. There's people who have greater genetic risk, as Nima was talking about, but the causality of schizophrenia is complex, and it's very hard to know who would or would not have developed psychotic illness in the absence of cannabis use. Some people would, not everyone who has genetic risk does, many never would. So cannabis may be acting as a trigger for this very severe illness. What does seem clear is that it is increasing the overall number of cases above what would have otherwise occurred. Dr. DeFordy in London estimated that maybe 12% of new cases of psychosis are due to high potency cannabis, for example. And those estimates ranged by city to as high as 50%, I think, in Amsterdam.
Right. And I should have mentioned in a previous slide that if you're using cannabis with just 10% of THC daily, it increases your chances by about 5 times to develop a psychosis. And remember from a previous slide that right now in the market, that's all we're seeing, cannabis products with well over 10% of THC content. And with regard to psychotic episodes, not only are you more likely to develop psychosis, but for those who have experienced psychosis or have a genetic predisposition for schizophrenia, you are more likely to have a psychotic relapse with continued use of high THC products. Now, in addition to psychoses, this is a good time to mention other mental health issues. Unfortunately, what we're seeing now is there is modest evidence that cannabis use can worsen suicide ideation, the number of suicide attempts made, and rates of suicide completion. PTSD is a bit of a mixed bag. There are 2 clinical studies over the last 20 or so years showing that synthetic THC, again, nabilone, Marinol, can reduce some PTSD symptoms, while another survey study, not a clinical trial, suggests that cannabis use is linked with worse PTSD symptoms. And then you have another recent clinical trial, I believe it came out of Israel, that compared 3 different strands of smoked THC with differing THC and CBD levels. None of them had a differing effect compared to placebo. So the evidence for cannabis and PTSD is completely mixed. For depression, there is no evidence to suggest so far that cannabis can help alleviate depression. I haven't seen a single clinical trial that compares placebo to a cannabis product specifically for treating depression. Most clinical studies you see on depression are looking at another health condition like MS or pain and measuring depression as a secondary measure. And even so, there appears to be no difference between a cannabis product and placebo. If anything, there's weak evidence so far that frequent cannabis use can contribute to developing a depressive disorder. But again, the evidence is still emerging on that. Now, among kids ages 8 to 12, cannabis use levels dropped off in starting about 5 years ago and have remained steady ever since. However, among young adults, late teens and early 20s, cannabis use has still been on the rise, regardless of education levels. And this is concerning because what we notice is consistently, as shown on this graph, according to one study, younger people who use cannabis frequently have lower education rates and greater rates of depression and welfare needs. So the more frequently you use cannabis products, the worse health and social outcomes you have. Again, the sooner you start with cannabis use.
Yeah, just correction. So it didn't change depression, but it did change educational outcomes, both for high school and college. So, and very significantly, I mean, for people using daily, this was a study done in New Zealand, but of a very large group of 17-year-olds following them through age 30. And the folks who were using cannabis daily just had their likelihood of high school and college graduation halved, basically. So as a society, we look at trying to get good educational outcomes for our youth. Anything that increases youth use is quite concerning.
And similarly, with the way we saw young adults having an increasing rate of cannabis use, we're also seeing an increasing rate of cannabis use among pregnant women. At least that's what we're seeing in California, as well as a declining perception that cannabis is harmful. And the issue here is that prenatal exposure or cannabis use during pregnancy has been shown to be associated with lower birth rate, greater rates of premature births, and greater ICU admissions or intensive care unit. So there's issues of fetal health that we're seeing with cannabis use during pregnancy.
Yeah. And I would just chime in here before you get to the next slide. When we think about equity, people talk about equity in the cannabis industry as economic equity and access to being able to open your stores. And we'll talk more about this in the discussion about equity. But I'm a pediatrician. Back when I trained and did my public health degree in the 80s, we were trying to focus on reducing very huge disparities in rates of low birth weight and premature birth, particularly in Black women in the United States. That was over 40 years ago. We haven't solved that problem. New research, just came out again this week, highlighting the disparities, particularly between Black women and women of other races in the United States in these basic outcomes for the well-being of their babies. So any factor that can contribute to increasing low birth weight and increasing these neonatal risk can also exacerbate existing health inequities that we've been trying to fight for many years. Sorry, Nima.
No. That's good. Thank you for mentioning that. That's important to keep in mind before we get to the equity discussion. And in addition to fetal health concerns, just after birth, these issues appear to carry on into childhood. So what we're seeing is by the time a child reaches age 9, when you have prenatal exposure to cannabis use, a child by age 9 is more likely to have psychotic episodes, issues with cognition, sleep, social problems, and a range of other mental health issues. And in addition to issues we're seeing with pregnant women and children, we're also seeing, interestingly, a spike in hospitalizations among older adults in California, age 65 and up. You're seeing, oops. There we go. Okay, so minor thing there. But we're seeing about 1,800% increase over the last 15 or so years in adults who are winding up in the ER, older adults, excuse me. And similarly, in just the last couple of years, we're seeing a major spike, well over 1,000% in pediatric exposures to cannabis. And of these, close to a quarter of them wound up in the hospital. So again, this is going back to the issue of if there are cannabis products lying around the house, especially edibles that are marketed purposely to kids to look appealing to children and young adults, that they be locked away and kept out of reach. And again, in future sessions, we'll talk about ways to perhaps regulate the existence of these products altogether. Now, there's also been a recent wave of hospitalizations you may have heard of due to vape use called E-Valley. And it's largely suspected that this is due to an ingredient called vitamin E acetate that's been added to bootleg vape products, especially to either thicken or dilute the vape liquid. Now, the cases mostly dropped off toward the end of 2019, I believe, but the overall effects of vaping are still largely unknown. We're also seeing a rising amount of cases in cannabis hyperemesis. This is when patients get sick due to cannabis use and have severe cases of vomiting and pain. Now, this too, Dr. Lin, correct me if I'm wrong, this may be another genetic issue and it's more related to cyclic vomiting syndrome. But that said, we are seeing a rising number of cases in CHS since 2004 when it was first identified.
Yeah, it's very clearly there's a group of people who are heavy users, basically, who develop this very severe cyclic vomiting, sometimes only relieved by hot showers, which is a very strange finding. And you'll find cannabis users taking incredible numbers of hot showers to reduce some of these symptoms. But this is very much a cannabis-associated effect. My ER doc friends call it scromiting. They'll have patients in the ER vomiting and screaming. On EVALI, the factor that was the most associated with cases was vitamin E acetate, but it was only present in a minority of the samples tested, I think about 40 or 50%. So there were many cases of EVALI where the causative agent was not fully identified. And there were cases with legal products as well as with black market products, illicit products. And there's a lot of concern that the inhalation of these lipid substances may be causing lung damage in other ways. So it's still, and there were also cases amongst just tobacco vaping patients, although the majority were with cannabis vaping. It does appear to have dropped off. So it may have been vitamin E acetate, but it's really not clear. And there's probably some degree of other pulmonary harm going on, but not as dramatically as the EVALI epidemic.
Right. Thank you for clarifying that, Dr. Silver. So did you guys get that? So vitamin E acetate was identified as one of the probable causes, but this is occurring in both legal and illegal markets, and there may be other components involved in these cases. So keep that in mind. Now, with regard to lung effects, what we do know so far, again, from that NASEM review, which I'll share with you guys later, that Dr. Silver was also referencing, which is that with frequent cannabis use, you will have more frequent chronic bronchitis episodes with long-term cannabis smoking. And overall worse respiratory health, I should also mention. And of course, we also have the risk of driving under the influence. Now, just as a side note, it is true that the police still do not have a reliable measure of looking at recent cannabis use, as cannabis THC can stay within the system for a long period of time, for about a month, if not more. But that said, there is substantial evidence that while driving under the influence, especially if you co-use cannabis and alcohol, that it raises significantly your chance of having a motor vehicle accident. Regarding cardio health, the research is still emerging, but the evidence so far is suggesting that frequent cannabis use can raise your risk of heart attack and stroke. Now, what about cancer? Since we hear so much about the harms of smoking tobacco and that link to cancer, so what do we know about cannabis? So far, there's modest evidence to suggest that cannabis use is not linked to lung, head, or neck cancers, but there is still emerging evidence of a link with testicular cancer. So let's wrap up here. Sure, when we compare cannabis to drugs such as cocaine and opioids, cannabis is not as harmful if our metrics are overdose fatalities, hospitalizations, and so forth. But frequent cannabis use, especially products with higher THC content, can still have serious health effects, especially on fetal health, youth, and mental health. The idea that cannabis itself has never killed anybody is somewhat of a myth. It could still have indirect effects. When we consider psychosis, impacts on those who are exposed to cannabis at a young age, rates of suicide and traffic accidents, cannabis can be indirectly involved with fatal incidents. So then the question becomes, okay, what do we do about cannabis legalization? How can we regulate the market properly in a way that doesn't go backwards and repeats the mistakes of the war on drugs, while at the same time making sure that we address the public health concerns that we've raised in this presentation? That's what we're going to talk about in the next session. But for now, that's our presentation. We ended just on time. We have about 10 minutes for questions. Please fire away. You can either throw them at the chat or unmute yourself.
And I would just add, because I know you are working on opioid issues and fentanyl issues, and these are very pressing, and we're seeing, huge increases in overdoses across the country. So the patterns of population health impact of these drugs are very different. With overdoses being a dramatic, life-threatening event that's killing people. Cannabis, what we see is a broader base of use in the population. So a much larger percentage of the population uses cannabis than uses opioids, fortunately. Not fortunately that they use it, but fortunately that the rate of use of opioids isn't that high. But because the percentage of the population that uses and the percentage of the population that uses heavily is very significant, representing millions of people, the population health impact of these negative effects on child development, on incidence of psychosis and schizophrenia, on car accidents can be very significant in how it affects the health of our larger populations. For me, any increase in psychosis and schizophrenia in communities is devastating, because we're already doing really badly at dealing with those issues, as you know, from homelessness, from the population in the street with poorly managed mental illness. We're not doing well with those conditions. So we have to be really careful about any public policies that can increase those risks, and what actions we take to minimize them as we regulate this new industry. So what questions do people have? Do you have any stories to tell? Do you have family members, friends, kids who've experienced these problems? Have any of you been pregnant lately? And what did you hear about using cannabis? And what were you wondering?
Thanks so much for this great presentation. I do have a question. I hear a lot from recipients about cannabis being laced with fentanyl, and I don't think there is any seizure of those products where analysis of those products supports that, but I hear a lot of recipients kind of putting that out into their communities, which is concerning if the evidence isn't there. Do you know if that's something that you're seeing, or you've seen, or jurisdictions are seeing?
I don't think it's occurring widely. I know the high intensity drug trafficking area structures had received some reports of cannabis contaminated with fentanyl. I don't think there were a lot of confirmations, and we haven't seen a lot of cases of it, certainly. But it is a good reason to use legal market cannabis rather than illicit cannabis. I think one of the messages we do say is, if you are going to use cannabis, use legal cannabis where it's available in your state, because it will be tested for contaminants and is much less likely to have fentanyl or anything else bad in it, like spice or other things. That said, it doesn't seem to be a huge problem, but there may have been a few cases. It's been, I think, the high intensity drug trafficking areas hadn't been able to confirm very many. At least the California one. I actually haven't looked at all the state reports. I don't know if anyone else has had experience in the states that you're working with. Has anyone else heard of confirmed cases in your states? Or Nima, have you?
No, I've been hearing more about cocaine laced with fentanyl, that being a more prominent issue, but not cannabis related, cannabis laced fentanyl. I could check the Rand Corporation's Drug Policy Research Center to see if there are any reports on those cases and get back to you guys.
Yeah, we don't promise to have the answer to every question, but if there's one you ask that we don't, we'll try and find the answer and get back to you. And if you have questions that, rise in the coming months in your field work and you want to, send us a question or something, we can also try and get you a response. Just let me ask a question. How many of you were familiar already with the psychosis risks? Can you do a thumbs up or a thumbs down on the reactions? I'm seeing
Couple.
3 or 4 thumbs up. And people, for the most part, are just not aware of many of these risks. And they're quite significant. And even many clinicians are just becoming aware because like the data on psychosis, the first studies were old, but because the risk was lower with the old-fashioned or more traditional botanical cannabis, awareness of this as a major issue was not that widespread. And now what we're seeing with the industry being legalized is that it's transmitting a message that it's safe. Oh, it's legal, it must be safe. And the industry is marketing cannabis as a wellness product. It's putting it in little gift bags at the Oscars and, having, bridal showers with cannabis and, together with your spa treatments and so on. And so it's creating a whole public perception of safety and wellness that is not accurate, even though there are valid medical uses in certain situations. There is much more harm than benefit. Or at least that's my perception as a public health professional. We do hear from many teenagers that they take it to reduce stress, and they think that it's a natural and safer way of reducing their stress than taking other medications. To me, the evidence suggests that that's really not the case, that the harms, especially that a teenager may face, or the impact on their educational outcomes, may be much more negative than positive. But we're really working against a tide of marketing and rebranding of cannabis as a wellness product nationally that's heavily influencing public perception. Many pregnant women think that they could take it to treat nausea and that it would be safer than taking medications for nausea, whereas it may actually have significant negative impacts on the neurological development of the infant. And so this is changing these public perceptions, I think, is a huge challenge that faces people such as yourself and your drug-free communities projects, and yet not falling back into war on drugs lingo, because there's rejection of the messages from the war on drugs. For example, Reefer Madness was, racist film that typified the war on drugs mentality and exaggerated effects. And yet there is a real risk of psychosis and schizophrenia associated with cannabis use. So, but often when we talk about it, we get accused of going back to Reefer Madness discourse. So even though National Academy of Science and the psychiatrists and everybody else says, no, there is a higher association with psychosis and schizophrenia, there's a lot of rejection of that message as a fallback to Reefer Madness. So figuring out how to communicate that risk is real through stories, through experiences, through families, often it's parents who are the most affected, who've had kids affected by this, who are the most effective spokespersons to explain what happened and for policymakers to understand that, no, this is real, just as Mothers Against Drunk Driving were some of the most effective advocates in the past. But
This touches on the messaging issue as well, which we'll talk about in later sessions. There, something that our team has had to deal with is walking that fine line between science and making sure that we put out good policy. There should be a way to balance having an effective public health policy without parroting kind of legacy cannabis laws and the harmful social impacts they've had. There should be an effective way to message the harms of cannabis without seeming anti-cannabis, which we'll talk about in future sessions. And additionally, Lynn, I think this is a good time to bring up Delta 8 and other artificially derived THC products, because we've talked a lot about the risks of high THC products, but remember that with hemp being legalized, there are artificially derived THC products where we don't have a lot of information on what those health effects are, yet they're completely legal. So that's something else to keep in mind with regard to drug policy and cannabis policy overall.
Yeah, thank you, Nima. That's a great point. So as he was discussing, the Farm Bill had legalized hemp, with less than 0.3% THC, but then products for oral consumption, foods, supplements are in a very nebulous place. The FDA recently declined to treat CBD as a supplement food, in part because it already is a regulated pharmaceutical, approved by them through their pharmaceutical process. But yet it is being sold widely across the country. CBD itself is not entirely safe. Consumption of high amounts can cause elevation of liver enzymes, some reproductive toxicity, and it's also has medication interactions, but it's much less problematic than THC. But what we're seeing with hemp is that 0.3% criteria made sense for the flower, like smoking hemp flower won't get you particularly high. But if you apply that 0.3% to final hemp products like gummies, you can pack a whole lot of stuff into of psychoactive THC into those products. Mostly what the hemp industry is doing is they're taking the high CBD content of hemp and they're chemically transforming that into other cannabinoids that are intoxicating. That's Delta 8, THC, Delta 10, hexahydrocannabinol, which is HHC, something called THCO acetate are the main ones. These are cannabinoids that look and act like Delta 9, the traditional THC that's in cannabis. They can get you very high. And there are packages of these hemp products being sold in gas stations, smoke shops, vape shops, all across the country, both in states that have legal cannabis state systems and states that do not. So it's good to be aware of what the situation is in your state. I bought a bag of Sour Patch Kid hemp gummies in a vape shop where it was available for sale to a 10-year-old 3 weeks ago. And these gummies had 100 milligrams of Delta 8 THC per gummy, 1,000 in a bag of 10. So it was 10 times the amount of psychoactive substance in each gummy than the maximum allowed on the legal cannabis market in California. So one of these gummies would have floored me. It would have put a young kid in the hospital if they ate it. It was designed to look like a Sour Patch Kid figure, bright green and blue and multicolored stuff. So in addition to the whole problem of the legal cannabis market, we now have this parallel issue of hemp products. We strongly encourage as a policy initiative not allowing the sale of, I would not allow the sale of any of foods or supplements or drugs with any active cannabinoids outside of a restricted cannabis market, but particularly the ones that are intoxicating, like Delta 8, Delta 10, and others. should not be allowed. They certainly should be age limited at a very minimum, not be sold to anyone under 21. We are seeing episodes in schools with kids getting their hands on a bag of these and multiple kids getting taken away by ambulance to the hospital. The school's concerned that it might have been a fentanyl overdose. They turned out to be cannabis overdoses because kids are getting their hands either on legal or illegal cannabis edibles or hemp-derived edibles. Doesn't really make a big difference from a medical standpoint, but from a regulatory standpoint, it adds a whole new layer of complexity. So being aware in the states that you were working in, what the situation is, both with cannabis, illicit and legal, and with hemp products is important. If people have any questions about that, it's a really confusing, particular new twist to the whole cannabis situation in our country. And it's basically the same plant. Hemp is not different from cannabis. It's all cannabis sativa. It just has different levels of intoxicating cannabinoids.
Yeah, I don't have any questions about that. How you doing, Lynn and Nima? This is Brenton. I signed in late from another meeting, but I do think that since we are starting to see, more news about hemp-derived substances, I think we might need to talk about possibly another session about that. I posted an article into our branch MS Teams channel this morning about DA announcing that they were going to classify 2 substances as controlled substances. So this might be something that we can start to hear more about from our coalitions over the next year. And I know some coalitions are already doing a lot of work with CBD and have some of the same concerns you just shared, Lynn. So that might be a good future session, just making sure we can accurately and intelligently talk to our coalitions about the difference between these 2 plants, but also recognizing that, just because of the Farm Bill in 2018 doesn't mean that CBD is 100% safe. It's not. We need to still be able to communicate the dangers around that. So that might be another good session for us to have. But as long as we're coming up on progress report reviews, if you start to see some of these substances mentioned in progress report reviews and APRs and future 12-month action plans, please take a look at it and read it. Think about some of these trainings that we're going to be getting from Lynn and Nima, and apply what you learn here. But as you're doing those reviews and you're reading through that, if you see something that you don't understand, let's bring it back to these 2. Let's make sure we use their expertise to better understand what we're reading in these deliverables.
Yeah. Do any of you have questions you've gotten from your coalitions on the health issues? I know on hemp, for example, one of the things we're trying to do in California, we're trying to change the law both at the state level, but we're also working because state change can be so slow with local governments and local activists in different cities to try and get local prohibitions on the sale of intoxicating hemp products. So often we work both at the state and the city level. I kind of think of this kind of work as the analogy I used to use in food policy was an amoeba. You move forward where you can, and how amoebas kind of go like this and slide forward where there's space. Sometimes getting policies adopted or spread is almost like amoeboid action. There'll be places and windows of opportunity and governments that are more friendly to public health oriented policies, and you have to kind of jump on those, and those create the first examples. And once a city or a county has done something, the one next to it is more likely to do it, and then things spread, and then they eventually become state law and federal law. I worked on, for example, the first trans fat ban in the United States in New York City, and we did it in New York City, and then immediately other states, and we copied it from Denmark. It wasn't our idea initially, so we stole a good idea from somebody else, and then a lot of people stole it from us, and it spread, across different state and local governments in the United States. And by 2015, it was a federal policy. And I think addressing, many public health problems has had similar trajectory.
And
Hi.
this is, please go ahead.
Hi, this is
So-
Michelle. I was gonna say, I was really about to add the same thing that you were talking about, Lynn. I think a lot of grant recipients are just having a lot of issues when it comes to all the different state policies and the progression, especially in our northeastern states, in places like New York and things of that nature, trying to figure out how to give out educational resources to their youth, even when you have the state saying that it is legal and people are looking at it as a more safe type of product. So just trying to figure out how to give out educational resources to the youth that also express those, I guess, a little still those fears about the products, and also kind of staying in line with some of the state things that have came out too, especially because it's becoming the issues as people's parents, youth's parents are using, and it now is a legal product. And saying that your parents are wrong, it's kind of a little bit of a hard situation to kind of go around. So just trying to figure out educational materials that the youth can receive that also doesn't kind of put parents in a weird situation as well.
Yeah. I mean, one example you can always use is tobacco's legal and parents smoke it, but it doesn't mean that it's good for them.
Right.
So that's one analogy. I mean, another avenue of messaging is weed can wait, is one message that some coalitions have used, which is just really highlighting that until you're age 25, your brain is still developing and has greater sensitivity, greater likelihood of developing cannabis use disorder and so on. So that, as opposed to a full abstinence message, a weed can wait message has sometimes been more successful. And other messaging around youth, about how it can interfere with youth doing the things that they want to do or accomplishing their goals, and being successful at pursuing other goals. But we need a lot more investment in testing of messaging. I would like to see more of the cannabis tax revenues going to prevention. Not all of that should be education campaigns. It needs to be other types of investments as well, but some of it should be, the same way significant tobacco education campaigns have played an important role. We need to understand what kind of messaging works and what doesn't, and to fund that.
Thanks so much for the feedback. I'll be sure to pass some of those campaigns on to our coalitions. Thank you both for today.
All right. Thank you, everybody. We look forward to the next talk, which will be on policy initiatives. Nima, did you want to?
Yes, one quick plug. The NASEM review from 2017, I put it in the chat. This is something you're going to want to hold on to. So before we go, this is where we got a lot, where we're getting a lot of our clinical evidence from. And I'll talk about it real quick and then we'll be good to go. What they did was review all clinical trials since the late 1970s and 80s and summarized what we know completely so far about the good and the bad effects of cannabis, the therapeutic effects and all the harms. This is a good resource to have on hand, and we highly recommend you check it out. After this presentation, we'll send you both the slides, which have citations to all the sources we used, some additional info, and additional articles that'll be helpful for what's happened since the NASEM review. So keep that in mind.
And can you go to the last slide that has our emails in case anyone wants to get in touch with us? And I'm putting them in the chat as well.
Sorry, everybody, almost there. There we are. Please feel free to contact us if you have any questions. We're happy to help.
Recommended curriculum. There's some, we did a recent publication with Samson preventing youth marijuana use. We can share that with you as well. Nima, can you put that on our to-do list? There was a question in the chat about recommended curricula.
Just added it. Awesome. Great question.
But a lot of it is sometimes not just drug education, but really addressing the factors that are pushing kids to use, helping them with other life skills, mentoring, and alternatives, sometimes more than just knowledge. But we'll try and share some of those tools. So with that, I think we need to wrap. We're getting Brenton, did you want to add anything before we go, or?
I did not, but thank you all for your time. Like we said, there's a schedule out for future trainings. That's just what we were able to come up with. But if there are other topics that you all, as we continue down this road, want to discuss with Lynn and Nima, please let us know so we can work with them to get those trainings set up. But I hope everybody enjoyed it today and hope you learned something. Thank you very much.
Take care.
All right, thank you, everybody. Good meeting you.